responsibilities over some other areas. And then a chief financial officer, who is oh, that's you. That's Lisa Walker. And Lisa is here and just does an incredible job for us, and with Kelly as well, and I couldn't be in better hands with having the two of them, so thank you both very much. Why the change? We believe that the healthcare environment, not only in Georgia but nationally, is changing, and we needed to prepare the department to be more responsive to the healthcare environment needs of the future. The growth in Medicaid and the CHIP is outpacing private insurance. The increased focus on outcomes. You all ask us a lot for healthcare analytics, and how are we doing, and how can we use that to help inform our decisions, both policy and budgetary decisions, and we felt that we needed to invest more time and energy into that. And facilities are becoming less centralized in patient treatment, and we're starting to see, and you all are very familiar with this, a much broader approach to serving the whole person. So we're looking at that. Our health system has been falling behind. Our Medicaid division, for instance, is based on about a 20 to 25-year-old platform, and we needed to update that. So a lot of our IT needs are both federally mandated, but also there are some things that are Georgia-specific that we need to be able to do in order to address the population that we're charged with serving. Moving forward, and then I'll be very brief with this, we are establishing a project management office so that we can make sure that we're staying on target and that we will have good outcomes to be able to demonstrate, not just to the governor, not just to you all, but to the people that are invested and interested in our department. Again, healthcare analytics and reporting. That's been in another division within the department, and I don't believe we have been getting the bang for the buck out of that division. We've just not been utilizing it to its full capacity, and I think once it falls under our new chief health officer, we'll be able to use that in a much more meaningful way for the department. And continuous program improvement. I think the governor has been very clear that he wants a reduction in administrative burden. There's a balancing act between a reduction in administrative burden, but also ensuring quality. And how do we marry those two? So continuous program improvement is something that we've been very, very focused on. I think we've talked at one point already about, for instance, the Katie Beckett example, and we don't have to go over that again, but Chairman Hawkins, even looking at that, we're now looking at, can we even extend that out a little bit further for certain health populations that the individuals are not going to get better. And so we're looking at those things, so thank you for your insight on that. So we can certainly answer more questions. I'd like for Lisa to walk us through the 20 budget requests, and then we can answer any questions that any member has, and then certainly have one-on-one meetings if there's more detail that needs to be given. Lisa? You want this?
Very briefly, I'll go over the current year budget. We have already addressed that in the amended year, so I'll do that very briefly. In the current year budget, we have $15.3 billion in Department of Community Health, with $3.3 billion of that is state funds. Okay. We have $15.3 billion at the Department of Community Health appropriated to us, with $3.3 billion of that in state funds. 97% of our appropriation goes to our benefit programs, which is age, blind, and disabled, and low-income Medicaid, and that does not include the state health benefit plan. Moving into our recommendations for fiscal year 2020, I'll start with our Departmental Administration and Program Support Program, moving into our benefits program. I'll start with mentioning each tracking number, then go into the request. 17.1.7 is for background checks. Background checks is in regards to the implementation of Senate Bill 406, which required for us to provide increased background checks in the long-term care facilities, and that request is in the amount of $737,639. The next item is 17.1.8 for third-party liability. The third-party liability, as it relates to this request, is for a reprocurement of our third-party liability vendor. And this third-party liability vendor actually go and seek additional payments to pay for Medicaid-related services because Medicaid is supposed to be the payer of last resort. So this would be a reprocurement of that particular vendor in terms of the third-party liability contract. And the amount is in $1,803,250. The next item is 17.1.9 for CHIP enhanced FMAP adjustments for administration. For the next, beginning at the beginning of October 1, 2019, the enhanced FMAP for CHIP will be decreasing from 100% to 88.61% in terms of the reimbursement rate, and this is a reflection of that, and the request is in the amount of $3,708,763. The next item is 17.1.10. It's to utilize existing funds to expand Medicaid asset verification system. And this is to, for the verification system of the assets in which a particular beneficiary might have in terms of verifying their eligibility to come onto the rolls. And this is to change IES so that it can capture all categories within ABD outside of the institutional category that's currently is in place. And that's a yes item because it's utilized existing funds. Moving into our benefits program, which is age, blind, and disabled, low-income Medicaid, and Peach Care. The first of those items is benefits growth, 17.7.1, 17.8.1 is for benefits growth. This is the growth in benefits related to utilization, demographic trends, the medical inflation, general medical inflation, and any increased enrollment growth as it relates to the general population. And the amount of that request is $88,885,270. The next item is 17.7.2 for Medicare Part B, and this is the Medicare Part B for dual eligibles, which pays for the premium as it relates to those who are eligible for Medicare and Medicaid, and that request is for $6,839,224. The next item is 17.7.3, 17.8.2 for gene therapy. The gene therapy is two types of gene therapy class drugs that's been approved by FDA, and these drugs will become available for those who are recipients of Medicaid. And as a result of that, we are actually removing the outpatient cap so that the beneficiaries can receive these therapies if they are in need. And the request for that amount is $5,926,010. The next item is 17.7.4, 17.8.3, 17.9.1, and this is the FMAP adjustments in age, blind, and disabled, low-income Medicaid, and for Peach Care. And the request for that amount is $92,022,629 for that request. The next item is 17.7.5, 17.8.4 for IPPS Phase 3, which is Inpatient Prospective Payment System, is a system in which Medicaid reimbursement reimburses hospitals for inpatient hospital stays. And the agency is proposing to update the reimbursement system as it relates to that, and that request is in the amount of $9,275,234. The next item is 17.7.6, which is long-term acute care. DCH is proposing to enroll new LTAC and intermediate rehabilitation facilities. As Medicaid providers, there will be 7 LTAC and 3 intermediate rehabilitation facilities that will become Medicaid providers for fiscal year 2020. And the amount for that request is $3,168,093. 17.8.5 is the health insurer fee moratorium. This is a reduction of $34,439,780. This is a federal requirement where there's a moratorium where insurers will not have to pay that particular fee for fiscal year 2020, and this is a reduction as it relates to that health insurer fee. 17.8.6 is the hospital provider fee payment in the amount of $10,410,506. Each year, we give revenue projections to the Governor's Office of Planning and Budget based on revenue that might come in, and this is a reflection as it relates to the incoming revenue for hospital provider fee payment for benefits program at DCH. That concludes the Department of Administration Program Support and Age Blind and Disabled and Low-Income Medicaid and Peach Care Program. The next slide actually just covers the statewide changes in various programs that OPB usually adds into each agency's budget as it relates to changing operational costs. And these are the statewide changes that's reflected in that. I can go over each one, but I can skip and go into state health benefits if you like. You want me to go over each? Okay. The next slide is state health benefits program. In state health benefits program, you will see yes items reflected in the FY 2020 request column. And that's because these are other funds coming into SHBP from agencies as it relates to the paying on the behalf of the state employees that work at those particular agencies. And the first of that request is 17.10.1 to reflect updated growth, and this is similar to Medicaid with increased utilization and medical trends that's in the program, and the amount to increase state health benefits is $224,651,921. The next item is 17.10.2. This to reduce funds to reflect savings from the Medicare Advantage rates. Each year we renegotiate our agreements with our TPAs in order to provide health care benefits. And as it relates to the Medicare Advantage plan for those who are 65 and above, they had a reduced premium to pay. And this is just a reflection as it relates to those savings within the Medicare Advantage portion of state health benefits. 17.10.3 is the next item. To increase funds to reflect enrollment growth for mental health parity. We have included mental health parity coverage within the state health benefit plan that will provide for ABA therapy, residential treatment centers for methadone coverage, and this will be new coming into the calendar year 2019 for the state health benefit plan. And that amount is for $7,940,000. The next item is 17.10.4. is to reduce employer share of the state health benefit plan from 30.45% to 29.45%. This is a reduction of $32,218,604. State agencies will pay less, 1% less on behalf of state employees in terms of their premium benefits that they receive in each individual Department of Community Health and as it relates to state health benefit plan. That concludes the presentation for Department of Community Health related to our budgetary items. We're open for any questions.
Good. Thank you very much, Lisa. Do we have any questions from the committee? Well, obviously you did a good job. Thank you very much.
Thank you. And I know that finishes our 2020, and that's our last budget presentation for the year. I know there'll be subcommittees, but thank you very, very much for your support. It is greatly appreciated. Thank you.
Thank you. Y'all deal with a tough subject over there. Okay, next we're going to hear from Ms. LaShawn Hughes. She's the Executive Director for the Georgia Board of Physicians Workforce.
We're loading our program. Mr. Chairman, we're ready. Thank you for the opportunity to come and talk about the board today. I wanted to introduce our staff. Daniel Dorsey is our outreach coordinator. He works with our medical affairs and outreach. Freeman Montague is our budget director and handles all of our budget items. For the Board of Physician Workforce, we have 6 budgetary programs, and they're listed here. On 17.11.1 and .2 are the state programs for the governor's recommendation. 17.3, we're utilizing $35,231 in existing funds, and that is to cover our data visualization tool. It's on our website, where you can look at our website and see where people are, where doctors are in each county, what their specialty, what the demographics mix is. So we want to upgrade that, so we're going to take those funds, existing funds, and upgrade that program. You'll see on our next page is some of the other items we use in our administrative budget. And 17.12 is graduate medical education. We have 17.12.1 is for 112 new residency slots. 17.12.2 is for FMAP. So our program net change is $2.4 million. The next slide talks more about graduate medical education, talks about our accredited positions, what they are, how many the board funds, and how much we spend on that. It's for the next 2 pages. For 17.13 is Mercer School of Medicine. There's no change to that, so no program net change. And we included some additional information just for your information on what Mercer uses their operating grant for. So that's your next slide. 17.14 is Morehouse School of Medicine. There's no program net change for that. And our next slide talks about Morehouse operating grant and what they use it for. Our next slide is Physician for Rural Areas, is 17.15.1. It's increasing funds for loan repayment programs for $500,000. And our program net in that area is $500,000. Our Physicians for Rural Areas program is information about how we spent those funds in FY19. So we provided that information on where we spent it and how it was used. We also like for you to look at our map. The red map, the red squares are the counties that were already in our program, 35,000 or less. But the yellow shows the new counties that we've added. The board changed the rules from 35,000 to 50,000, which added more counties in order to be eligible for loan repayment. So we're very pleased to add those. And our good news is these are the counties where we have loan repayment recipients at. So we're excited to have them in South Georgia and Southeast Georgia. 17.16 is undergraduate medical education. There is no net change in that area. And we included additional information about the participating medical schools in your packet. We gave you information on medical school enrollment for 2019 through 2020. We have the 2018 match results from all of the programs. That's a part of our programs. And we, well, I guess I should highlight that 30% match to a Georgia GME program, which is pretty good. Our aging workforce is something that we always talk about from our demographics. And just to note, in 2017, over 50% of the workforce is over the age of 50. So we have some other demographics there as well. We included the GME exit survey about the debt that doctors have when they graduate from medical school. Our average debt is $234,000 for each physician. So this is why our loan repayment program is important. It's really helpful to them since they could get $100,000 from the state. And our last page is just a summary of all our programs and how much the governor's recommendation is. Thank you, Mr. Chairman. I'll be happy to answer any questions.
Okay. Do we have any questions from the committee? Sean, I've got a couple of questions for you. On the student debt over there, I was just looking at this. I hadn't seen this number before. The average debt's $234,000 in Georgia, I guess if I'm reading this right, and the national average debt's $192,000. Why is there such a discrepancy there?
Well, we've asked some of the students why their debt is so high, and the answer I've gotten is that when you don't have a job or you're trying to get into medical school, a lot of the expense is flying around you're basically living on your loans, on the debt. So they're flying around for interviews, traveling to get matched, and using the money to live on. It's not the schools that are so expensive.
So it's not just tuition, it's other things as well.
Right.
Okay. Well, let me ask you this. I've always been concerned with the number of Georgia medical school graduates who are in our GME slots, or our program residency slots and all. And it's a low number, it looks like to me. And I mean, I know we're never going to have 100%. We don't want 100%, but surely to goodness it ought to be up from where it is. And I guess my question to you is, do you have any suggestions or ideas about what we can do to improve that?
Chairman Parrish, we have a committee called the Medical Education Advisory Committee, and they're looking at this to see what can we do to keep our students here, keep the residents here. So we meet, we generate ideas. We have all of the medical school deans and program directors meet with us to try to come up with solutions to keep people here. It is kind of hard to make a commitment when you're 25 and live with it when you're 29, but they're working on it. They're trying to recruit more Georgia residents, looking at the pipeline of people who have gone to high school here, went to college here, and recruit those types of students.
Okay. Representative Hughley, you have a question. I've got it on. I'm not sure.
So we plan to give 13 physicians $25,000 each. So these will be new loan repayments. So we're planning for 13 physicians to get additional loan repayment programs, 10 advanced practice registered nurses and physician's assistants, and 3 dentists, which would equal the $500,000.
Going back to Chairman Parrish's question, you know, back when I was at Emory, I know the Emory Grady program was one of the most sought after in the United States. So I think part of our situation is that program probably still is, and it crowds out a lot of our Georgia residents. I know that we're building our numbers up in other hospitals. So I assume that we'll see that percentage of Georgia residents increase over the next years as we come on with these programs?
Yes. So the Governor Deal's initiative to increase the programs, it was a stricter format for that. So when that plays out through 2025, I think you'll see more people matched here in Georgia.
Right. Thank you. Yeah.
I have a question. Did you get me? Yeah. Thank you, Ms. Hughes. Quick question as it relates to our physicians in all of our Georgia schools in the aggregate. How many of those students are Georgia citizens, and how many are from out of state? Do you know that?
We have that information. It's not in our PowerPoint, but I could get that information for you.
I'd be interested. I think all the members would.
Yes, sir. We have that.
Thank you very much, Mr. Chairman, and my friend of many years from LaShawn.
Yes.
I've been watching the Mercer Medical School and the Morehouse Medical School kind of as private institutions started at the same time, kind of go hand in hand, and the funding has been pretty much the same for each. Is there any possibility that Mercer will have an opportunity Mercer, Morehouse will have an opportunity to get some additional funding so that they will match the expansion that Mercer has achieved which we're all very proud of.
So the board supports any expansion and development, GME development, but it's really up to the General Assembly.
I see. Thank you.
Okay, do we have other questions from anyone, members of the committee? LaShawn, tell us how far along we are with, Governor Deal's initiative to create 400 new residency slots with the great program. We're about there, aren't we?
Right, and in the end, we think we'll have 615 slots instead of the projected 400.
Now, if we could just get Georgia graduates to fill those slots, we'd be doing all right, wouldn't we?
Absolutely, we're working on it.
Yeah, okay. All right, any other questions from the committee? Okay, go ahead.
We had a medical fair last August, and one of our speakers was a financial planner and a student that had gone through the program. And she talked to the residents about, as soon as you get out, you make money. You're making $65,000. Now you're making $265,000. You buy a Mercedes. You buy a $500,000 house, and you still have that debt. So we are trying to incorporate that into our medical fairs when we go out and talk to them.
Sharon, you touched on this, but talk about this a little more. We put some money in there last year to help with the medical fairs that we had, been struggling with. Can you give us sort of your thoughts on how that's working out, and if that's something that we need to continue, and it looks like it's helping, or what?
Yes, sir. We had the medical fair. It was the first one we'd had in a few years. So we had 50 exhibitors, 89 residents that came through. We had it at Cobb Galleria. We tried to have it in Macon in a more centralized location, but it was hard for us to get rooms and meeting space there. So we had a good turnout. We did have one of our successes is that it's hard to find a psychiatrist. And it was a couple of psychiatrists that came through, and one just applied for licensure. We told her to keep up with us when she actually decided to move here. So we don't know where she's going to practice, but she did meet a lot of people at the medical fair. So the counties that were there were pleased that we were doing it again and asked us to continue to do it, although it was starting out pretty slow. They felt like we would build it back up again.
Yes, ma'am. And I'm seeing here, looking through the data, we see recruitment of all the different primary care physicians and OBGYN. We know that those are critical areas. But another area that I have noticed that we have a critical need in Georgia is for psychiatrists.
Right.
So can you speak to our kind of successes in recruiting psychiatrists and the degree to which we're having success there or not?
So I don't think we have data on that, but we do include them in our loan repayment. So we would rank them, especially in a rural area, if a psychiatrist wanted to go there, we would rank them pretty high to make sure they would be interested in going. So information on how the recruitment is, Daniel will check on that and see what we can find out for you.
Okay, do we have any other questions from anybody? Okay, thank you.
Thank you.
Thank you for your presentation.
I'm next. Yep. Next again.
Okay, yeah, we're going to get to talk to you some more about the Georgia Composite Medical Board. Just flip the page there.
Okay, so first I'd like to introduce our new Deputy Executive Director for the Medical Board, Lisa Norris. She joined us in November, so you'll be seeing her around. The Medical Board did not have any changes other than the governor's recommended changes, and our program net was $26,155. I included the licensure count for your information, and our revenue stream, our total budget is 2.7, and the board collected 7.1 last year in revenues. That's it, Mr. Chairman.
Okay. Any questions on the Composite Medical Board? Thank you.
Thank you.
All right. Next, we're going to hear from Dr. Pat O'Neill, Department of Public Health.
Thank you, Mr. Chairman and members of the committee. It's a pleasure to present to you today. And we'd like to also share what Commissioner Berry said. We really appreciate Tara. I'm going to start out with a little bit of description of what we think the funding that we are asking for is going to be doing for us in terms of programs. But in the interest of time and respecting your time, if I get too wordy in that and you want me to move to the numbers, just raise your hand and I'll stop and we'll go to the numbers. The current initiatives are listed there for you. The prescription drug monitoring program has been a very important part of our initiatives related to dealing with the opioid crisis and addictive disease crisis in Georgia. We've been striving to become more of an academic health department, and by that what we mean is having relationships with academic institutions across Georgia and outside of Georgia. Our number one priority has been and still is early brain development. We've expanded that a bit, which I'll explain later, and that's why you see Alzheimer's registry down there, because we're really talking about the full spectrum of brain development from basically pre-birth all the way through full life. Maternal mortality in Georgia is of tremendous concern to us, not just mortality, but morbidity. If you look at Georgia's mortality rates, they're 3.3 times the national average. That's totally unacceptable. Morbidity rates are even worse. It's 5 times the national average. So we have a lot of work that we need to do there. In a previous session, you may recall that developing a cardiac network was required of public health, and I'll be giving you an update on what we have done there and what this year's ask is to move that forward. Enterprise system modernization refers to trying to bring up to date our ability to use IT. Right now we have 18 health districts. Each one has a different IT system. None of them speak to each other. And in order to be able to give you good data from the entire state of Georgia, we really do need this. Emergency medical services has been with us for a long, long time, but they're being expanded to include a lot of things other than 911 calls, and I'd like to mention that to you as we move forward. PDMP has made a lot of progress in this last year. We now have all the states that are contiguous to Georgia, states that we can exchange data with. As you know, we had to change the law in order to be able to do that. That's working very, very well. Not only do we have the contiguous states, but we've got quite a few others as far north as Minnesota. What we also did that was actually required in the law years ago, but it did not happen, we've created an advisory committee to help us be up to date on what we do in terms of questions we ask and expectations in the PDMP. That advisory committee had its first meeting in October, second meeting was in January. It's going to meet quarterly. It's an just outstanding group of professionals that I think are going to be giving us really good advice on what we do. We realize that this is a real challenge for physicians and other practitioners to take the time to input data and to access the data. It's certainly a challenge also for pharmacists. And what we really want to do is make it as easy as possible for both the pharmacists and the practitioners to use this system effectively so that we can control the amount of particularly opioids, but we really need to go far beyond opioids. We really need to be thinking about all addictive disease, period. The other thing that I think is really important, probably the single one biggest ask that we're going to have down the road, is related to, again, trying to make the system as easy as possible for the users. And that is, we need to integrate the PDMP with existing electronic health records and records at the pharmacies as well. This is really critical. We do have some grant funding to begin this process, but not enough to do it statewide. It is so important to many of the large health systems that they have already paid to do it on their own. The slide says 80 hospitals and other organizations. As of last week, it's up to 90. So 90 different, fairly large organizations. Kaiser was the first to come on board. They created an interface between the PDMP and electronic health records. That saves a tremendous amount of time. Right now, you have to go into a separate portal to look at the PDMP data unless you have this integration. So what we want to have for the practitioners is, as they are getting to the point of prescribing a drug, we want them to be able to look maybe in the upper left-hand corner, click on a button and see what that particular patient already has in the way of drugs that have been prescribed that fall into this category that we're concerned about. Right now, we have over 38,000 prescribers that are registered. Roughly 99% of all folks with DEAs, with the exception of veterinarians, that they're not required to do this, but all other practitioners in Georgia that have DEA licenses are required by law to access the PDMP to participate in this. We now have 99% in the system. I'd like for you to just take a look at a couple of maps that are very, very important from what I mentioned to you before, and that's the sort of expansion of the way that we're using EMS. Obviously, for a long time, we've been working with developing a trauma system in Georgia. And we've done a pretty good job, but it's taken a long, long time. We started this in 1981, and now we have about roughly 30 designated facilities, counting both burn centers, trauma centers, and pediatric facilities in the state of Georgia. Essentially, what that means is that with major traumatic injury, we can get one of those patients with major injury into a trauma center within the golden hour, 95% of the time. So we'd love to have it 100%, but 95% is far better than we used to be. And the outcomes as a result of being treated in trauma centers is markedly better than when not in trauma centers. Stroke centers are another thing that EMS is really responsible for. The Office of EMS and Trauma basically has to designate the remote treatment centers, of which there are 14 in Georgia. And those are important because we use telemedicine in those centers to transmit head CTs back to a specialty center so that a neuroradiologist can make a recommendation on a stroke patient. Yes, this is a candidate for a thrombolytic or a clot-busting drug, or no, it is not. This is a bleed. You don't want to give that. In those remote treatment centers, you very often have a physician who does not have that skill to make that determination without a specialty consult. In these 14 centers, they can do that with telemedicine. We also have identified 5 comprehensive stroke centers, and those are centers where neurosurgery can be done if that's necessary, or actual intraarterial injection of some of the lytics, which is a very demanding type of specialty person to do that. So we're pleased to see that we're moving forward with that in Georgia. We also have 47 primary stroke centers across the state of Georgia. And if you look at what Georgia has seen over the years, since we're right in the middle of the stroke belt, the heart attack belt, our data has not looked good, particularly on deaths from cardiovascular disease. So creating this type of network, this type of system, where even if you're in a very remote part of the state, and we're not there yet with all those remote parts, but even if you are in many of these remote areas, we can get optimal stroke care quickly. And we didn't have that in years past. EMS has done a good job of the designation of these centers, so I'm really proud of them for that. On the next piece, you may recall also that we were required last year to come up with kind of a similar system for the cardiac network to be developed. Again, because of the fact that we're in the middle of the stroke, the cardiac belt. What we've achieved with trauma, we think we can achieve with many, many other things by rapid identification by EMS of personnel that need to go to a certain level of care center. Not just any hospital, but get to the right place at the right time. So starting hopefully this spring, we will begin the designation process of the cardiac centers. The top level, level 1 cardiac centers, will be those that also do open heart surgery, do left ventricular assist device placements, and some other specialty operations that you do not see in the next level, the tier 2 or the level 2 centers. Those centers are primarily PCI, percutaneous intervention centers. The level 1s can also do the percutaneous, obviously, but they can go beyond that. And everybody else, the lower level, is where any patient may show up and be referred to a higher level center if they need to go there. Maternal mortality is an area that has been very troubling to us. As I mentioned to you, the data early on. We were extraordinarily pleased that advocates last year were able to have an additional $2 million in our budget that was directed to improve things with maternal mortality. And I think we've done a pretty good job. You may remember the term AIM bundles. Basically, those are, it's really an opportunity to train facilities in proper management of hemorrhage and also some other conditions that are high mortality for a mother who's giving birth. Those training modules were initially in 10 hospitals. We, with that $2 million, have expanded that. We now have 16 rural hospitals that have these bundles in place and are able to more effectively manage the complications and prevent some of those complications that may occur with birth. So we're really pleased that the advocates were successful and that the legislature was gracious enough to fund that, because we think that this is an important step. It's not going to correct all of our issues with maternal mortality, but it's going to make, I think it's going to make the needle move considerably. So we're really grateful for that. We do have contracts in place with all 16 hospitals, and all are participating in providing report information for the Maternal Patient Safety Bundle Initiative for hemorrhage. Again, two major things that, and they're more than this, but hemorrhage and high blood pressure, hypertension, sorry about that, are the two main things that are taking our young mothers away from us. So these bundles provide additional training for these centers that are taking care of mothers giving birth in better management of those two conditions. The other condition that usually occurs in the first month to 6 weeks after birth is a cardiomyopathy. And many physicians are not prepared to see this in a young woman. Normally you see cardiomyopathy much later in life, but in pregnant patients in Georgia, this is probably right about the third major cause of death. So being able to diagnose that is probably going to be one of the initiatives that we push in the next year. As I mentioned to you, the IT system that we have is antiquated. We have been using the term ESM, Enterprise System Modernization, and what we are achieving there is an integration of all of our health departments, the data that we can gain from all of those health departments. And it's not just the actual electronic health record. That's very important, obviously, from the clinical perspective and for surveillance and monitoring conditions. But this particular system is also going to be able to do claiming and payment for us. And that's one area that public health has been kind of behind the times on, as so many of the things that we used to have federal dollars to provide at no charge to patients, those federal dollars are not there any longer. So we have a system where we do bill patients, but it's a sliding scale, and we do not turn anybody away for lack of funding. But if they do have the ability, if they have coverage, then certainly we need to take advantage of that to keep the system strong. I would point out that the thing that is different about public health from other areas of healthcare is the fact that we are population-based, population-concerned. We're trying to look at the impacts on the entire population of the state of Georgia and how that fits in with what we're seeing across the country as a whole. Next slide tells you something that is going on in a really bad way right now on the West Coast, particularly in southern Washington and northern Oregon, and that's the outbreak of measles. And you know, you think, well, measles is a disease of the past. Not so. We continue to see cases. Now, in Georgia, we have not seen that much. Typically, we have an average maybe of not even quite one case a year. Prior to this year, I think the largest number of cases that we had in a year since 2005 was 2 cases. This year, we've already had 3, and those were unvaccinated children, 2 of whom traveled here by plane and stayed with a cousin just north of Metro Atlanta, also unvaccinated. And that cousin came down with measles as well. So we now have had 3 cases here in Georgia. And, you know, as a kid, I never thought about measles as being dangerous, because back then we had a lot of unvaccinated people and we saw a lot of measles cases. But it's deadly. And when it doesn't kill people, it very often leaves them with neurological findings, hearing loss, sometimes damage to the eye, various types of problems that we see there. So we cannot take these childhood diseases as just mild things. They can be very serious. This next slide just shows the number of cases, as I mentioned, being so limited since 2005 until this year. And if we've already got 3 cases and we're just in February, we may see more before the year is out, particularly with what's happening over on the West Coast, and particularly with people being as likely to travel by plane to Georgia as they are. Flu activity is also with us, and I will tell you that Georgia had the highest number of flu cases of any state back in late November and early December. It peaked the next to the last and the last week of December. And I thought after that it was dropping precipitously and everything was looking good. And then all of a sudden 2 weeks ago, spiked up again. So the good thing, though, is that this particular flu virus this year, although it seems to be out there for a lot of people, we've seen a lot of folks that have caught the flu, it doesn't seem to be as severe as last year in terms of the numbers of hospitalizations have still been reasonably high, but not anything like the severity of those hospitalizations as we saw last year. And even this year, the death rate so far, we've seen 9 cases. 1 was a child. Last year, we saw 66 cases with 2 being children that died. So flu is still with us. We're very concerned about it. And if you have not gotten your flu shot yet, definitely still get it. Alzheimer's disease is very troubling. Roughly 140,000 Georgians are now living with Alzheimer's. We anticipate that by 2025, there will be 190,000 folks in the state of Georgia with it. If you look at the cost of Medicaid alone, $1.114 billion in 2018, a huge cost to the state. Medicare spending, $23,240 per capita. There will be a 40.4% increase that's projected by 2025. Notice the other figure of unpaid caregivers in Georgia. I was one of those. I took care of my mother for 10 years in my home. In the last 2 years, she had dementia. I can tell you, it takes a real toll on the family when you're dealing with this. And if you look at the cost that if we had to pay those folks that are taking care of dementia patients, Alzheimer's patients, $7.5 billion total value of unpaid care in the state of Georgia. Now, why is public health interested in all this? Because it's such a growing burden upon the state. It's such a heavy cost to the state of Georgia. It's a heavy cost both emotionally as well as physically as well as monetarily to the families that are taking care of these folks. And public health is always concerned about disparities in different population groups. There is a major disparity that we're seeing with Alzheimer's, so that's another reason that we're concerned about it. And the death rate from Alzheimer's, unlike other chronic situations, is not getting better, it's getting worse. We're doing much better with many of our chronic diseases, but not with Alzheimer's. So we've got a lot of work that we need to do there. The other problem is that we need to grow our workforce, and thinking about LaSharn's talk earlier, we certainly need more physicians that are capable of effectively treating and dealing not only with the Alzheimer's patient, but with their families. We divide all of our programs currently in public health into two different areas: health promotion, health protection. Our number one priority since Brenda Fitzgerald was commissioner has been early brain development. And you've heard us talk before about why that's so important. We know, based on the findings that came out of Harvard almost 10 years ago, Jack Shonkoff's work, that babies that have this good language nutrition, maybe even starting in the last trimester of pregnancy, develop pathways in the brain that you can demonstrate on CT scans and with electroencephalography. Those pathways create the ability for those children not only to learn better when they get to school, but also to be more socialized, to work in groups better. And I really would like to see some research longitudinally. I would predict that if, in fact, we can select a cohort that's had this type of good language nutrition early in life, and particularly if that language nutrition continues effectively throughout life, I have a great feeling that we will be able to see some changes in mental health conditions that currently are happening at large rates here in Georgia that can be avoided. Still to be determined. There's going to have to be a lot of research on that to tell. I think that the other message is that we are expanding that priority not just to early brain development, but we want to see brain development for the entire spectrum of life. Even at my age, we still need to be developing brains. Next page is showing some of our work at the Super Bowl. A lot of folks probably are not aware of how involved public health is with things that are kind of regulatory, particularly in terms of our restaurants, inspecting restaurants to be sure that the food is safe to serve. We had a real challenge at the time of the Super Bowl. Not only does Fulton have over 5,000 restaurants on a regular basis, but we had all sorts of new places that sprung up in the stadium and around the stadium that had to be inspected prior to or during the actual Super Bowl itself. We were expecting 538. We actually had 626 that had to be inspected. We had great difficulty on game day because NFL did not give us credentials to get into game day, and yet we were expecting 26 trucks to show up on game day that needed to be inspected before we could let them serve. It took the governor's involvement, his staff's involvement, in order to get those credentials, which arrived at 10 a.m. on game day, and by 5 p.m. that day, every one of those new vendors had been inspected. I had asked for 6 inspectors to be credentialed. They gave us 4. Those 4 folks worked unbelievably and got all those new vendors inspected. During this whole process, we did have an outbreak. It was a very small one with a foodborne disease. It actually occurred in a facility that was serving to first responders. It says on the sheet here 2, but there were actually 3 cases that we investigated. The first one turned out to be an allergic reaction, was not foodborne. The other 2 were foodborne. It was related to a toxin that showed up in rice that had not been kept at an adequate temperature prior to serving. We actually were able to identify also 19 illegal vendors that we shut down. You won't be able to see much on this map, but I would call your attention to the fact that the busyness indicates that we have telemedicine pretty much all over the state of Georgia. Every single county has a county health department. We have telemedicine, telehealth capability in all 159 counties. We actually only have about 25 actual clinical sites where we are doing telemedicine on a regular basis or telehealth. We want to continue to expand that, and if there is one thing that I heard repeatedly in the different study committees that were looking at rural health care issues, telemedicine was frequently mentioned as one of the approaches that would help us. And I agree, it's not the only thing by any means, but it offers us tremendous opportunities to offer specialty consults anywhere in the state of Georgia. So let's look now at the numbers. Perinatal health, this is related to previous legislation, which essentially has instructed us to develop the levels of care and to designate those levels in the perinatal system. We've had that system for a number of years, but it's always essentially been self-designated. We want to do it like we do other specialty care centers, like trauma centers, like stroke centers, like infectious disease centers, where an objective group goes in and looks at the site and determines, are you really the level you say you are, the tier that you say you are? So this $152,826 that we're asking for is to begin that designation process, which we hope to start probably later this spring. The next item, which is 38.7.5, child health programs, this basically is $70,336, and this is just asking for essentially a replacement of the funds that we previously were able to obtain from the federal medical assistance percentage that has been cut. So $70,336 there. The next is for public health laboratory. Now this is not the actual improvements at the lab. This is to purchase an individual, to fund a position at the lab. We have in Georgia still, even though we're working very hard to overcome it, we have a major issue with tuberculosis still. And this is to hire an additional technologist who will work in the tuberculosis section. And it's also for maintenance of the testing activity at the state lab on Claremont. Next item that you see is a fairly large one, statewide changes, basically $3,973,303. We are looking at about $6 million, I won't go into the smaller numbers there, to provide funds for the merit-based pay adjustment. We also, though, have several reductions that we have to take. Had a reduction of funds that reflect an adjustment in the employee's share of the state health benefit plan. That was $1,919,730. Adjustment to agency premiums for the Department of Administrative Services on self-administered insurance, that was $273,406. That was the public health share of that. We also had a decrease in funds to reflect an adjustment in cyber insurance premiums, also for DOAS, and reflect an adjustment in TeamWorks billings. For cyber, it was $24,644, and for TeamWorks, it was $24,389. Total changes come up to $4,345,985. Capital is on the next page, and this is where I won't go through all of these, just to tell you that the total is $2,300,000. Most of this is related to the fact that our laboratory on Claremont, as you know, we have two laboratories, one here, Indicator on Claremont, the other one is in Waycross. Waycross is the newer lab. The one on Claremont is now 21 years old, and we're beginning to see the need to replace a lot of systems in the laboratory that are essential. What a lot of folks don't understand, if you look down toward the bottom, you see a lot of funding that's requested for security. Well, why do we need added security for our lab? Many people in Georgia are not aware that we do a heck of a lot of essentially secret testing at our lab. We have around the metro area, right now, we had extra during Super Bowl, we have 17 secret sites that we monitor daily. We have collectors in those areas where air is sampled, and our lab tests those collectors on a daily basis to determine if any of the select agents, what are select agents? Those are germs that we know have been weaponized. Many are viruses, some are bacteria. Anthrax is the one that most people have heard about because of what happened after 9/11. But there are many, many others. We monitor that daily so that if there was a dispersal of any of those dangerous agents, we only have, with some of those, 48 hours to give prophylactic medications to the entire population affected. So it's important that we be able to do that. This would be an area that terrorists would love to knock out if they could get to it. So right now, the security that we have at the lab needs to be upgraded significantly. And that's what these additional charges are in the last three items that you see there. We have the same situation in Waycross to a degree. We don't do as much testing there as we do in the Atlanta lab or the Decatur lab, but we do some. So we've got to really be thinking much more about security requests. And these are what we're asking for this year. Once again, GO bonds to the tune of $2,300,000. The other thing that I'm going to mention, it's not an ask, but before I do that, just look at how our budget figures out. Federal funds of $395,951,809. That's 59% of our budget. That percentage continues to shrink. We, in the past, have had higher funding from our federal grants that we receive. We're actually getting more grants than we ever had in the past, but the actual funding amount for many of those grants has continued to shrink, which is something that we're striving to keep up by getting additional grants, but that number, the percentage, is just gradually going down. State general funds, $254,758,990, or 38% of our budget. And thanks to you folks, it's from the legislature that those funds have been given to us, and we appreciate that. We also have tobacco funds to the amount of $13,717,860, and other funding of about $10 million, and that basically is the refund amount that we get from the CMOs for the immunizations that we provide for them. The last thing that I'll mention is not a request, but it's basically to let you know that newborn screening is getting a lot of attention, and you probably have seen a lot of advocates around the legislature during session so far. We have our committee that has to approve the things that we screen for, has approved an additional 4 items that will be screened. And I sign off on those if I'm comfortable with the recommendation, and I have approved the 4 that the committee has recommended. There's another one in the works, CMV, cytomegalovirus, which we hope will be approved in the very near future too. And that's important because mothers that have CMV infection, particularly in the last trimester, give birth to babies with hearing impairment. But if you make the diagnosis quickly after birth, you can actually treat the CMV infection with antivirals, and you avoid that hearing loss. So knowing early on that you've got CMV is really important. So I think that will, in all likelihood, it's not part of the national recommendations, but we're going to recommend it here in Georgia. We actually had, in the grandchild of a member of my board, a baby born this last year with CMV infection. Fortunately, it was caught early, and I think we're going to do okay. But there are a lot of others that may have the same issue. So newborn screening is going to get a lot of attention, and we in public health would certainly support anything. If you have additional funds that you decide to put into this, we would certainly support it, although we're not making an ask for it. Happy to answer any questions.
Thank you, Dr. O'Neill. Representative Hughley has a question.
That's a great question. I appreciate your asking it because we've had a lot of discussion about this. And why do we see such disparity? It's not based on poverty, which is interesting. African American women that give birth, even if they fall into a much higher economic group, socioeconomic group, still have this disparity of maternal mortality. And the current thinking is that much of this is related to essentially added stresses that the African American faces on a regular basis. There was a grant that we were hoping to get. We did not get it. We had asked, I think it was about $1.1 million, where we really wanted to address the factor of stress and the impact that that has, particularly on an African American female during pregnancy. What could we do from a mental health perspective to change that. We did not get the grant, unfortunately. So we are going to be working with the Department of Behavioral Health to figure out if there may be other avenues where we can continue to explore what is it that we can do to, first of all, document that it really is the stress piece. There needs to be more documentation of that, but it looks like that's the issue. Much more so than the other social determinants that we know have existed and caused many of our disparities. But with maternal mortality, it's different. So we need more data on what's behind it. But we're pretty convinced that the stress piece is a large part of it. And working with behavioral health is going to be really critical to figure out what can we do to earmark special ways of helping pregnant moms, particularly during the pregnancy and probably even for a good 6 to 12 months thereafter, with stress reduction. We certainly have considered it, but that really is beyond our agency. But we have had conversations with DCH related to that very thing. I can't tell you how likely it is that it's going to come about, but that has been discussed.
Thank you very much, Mr. Chairman. Commissioner, seems like public health is finally coming to life, or just based on the number of questions that I have had and the interest that there's been. Some of your staff presented at the Women's Caucus the other day some statistics about maternal morbidity, maternal death, child death, and there was a fair amount of agitation about what we could do to improve maternal health and child health in our state. Representative Hughley talked about some of the issues that were brought up. I think we mentioned in the last meeting the importance of the maternal mental health grant that you tried to get. But there are a number of issues. The levels of care that were created, so you can get a designation, but then how do you implement the change that would result from what you've learned? I mean, I assume that doesn't just happen automatically. So it would seem to me that there would need to be funding for that as well. Can you talk a little bit about that?
I think you're addressing some really important things, and the number one takeaway message that I would like for everyone to understand is that there is not one single thing that causes the maternal mortality problems that we're having. And we have identified a host of factors that are involved, and we think that dealing with the hemorrhage and the hypertension is the first step. And I do think it's going to move the needle, but it's not going to move the needle all the way that we need to have it move. There are so many issues, and certainly in rural Georgia, access to quality care during pregnancy, and particularly prior to the delivery, is really problematic. We have major access issues. We have major issues with shortages of OBs, particularly in South Georgia, but even in other areas as well. And even where we have OBs, in some of the areas, the distances for women to get to those for their prenatal appointments is such that they don't make it. Prenatal care is really critical if we're going to move this needle too. And we've got several projects centering in pregnancy, for example, which is group prenatal care that seems to be, it has a great value because of the peer influences that you have in a group like that. We have several of those projects underway that we have essentially piloted, and we've shown better results both in infant mortality, and I think we can show it in maternal mortality too over time. So there are a number of things that are underway, but it's not one single thing. And trying to figure out which we need to do in priorities. You know, where are we going to get the biggest bang for the buck with the least amount of money to start with and then keep moving? That's our task. I think the AIM bundles, that was a good start, but it's not going to get us where we want to be. And I think the mental health piece may be our next most important piece, frankly. Physician education is also really critical, and nursing education, because nurse midwives are delivering some of these babies in some of our rural counties as well. So we've got to have ongoing education addressing this fact and figure out as many people as we can to get on this bandwagon. We can change this. It's just unconscionable that we could have this in Georgia.
The statistic that sticks in my mind is that 60% of the deaths were preventable. So it is time for us to take a serious look at all the factors that are adding to this. And I mean, where does our public health department funding fit on the scheme, on the national scale? Are we 49th still? Or
I don't have any comparison numbers. I could try to get some of those and let you know, but I don't have those offhand. I do think that one of the most valuable things that we've seen is the development of the Maternal Mortality Morbidity Committee.
That the OBGYN,
and
yeah.
Right now, every single maternal death is being investigated, and those folks that are on there are just extraordinary experts in this and are giving us feedback on what's preventable, what's not preventable, and what the real cause of the death was. And it's that part, I think, is really helpful to public health, because one of the things that we tend to do more than any other medical group is that we have surveillance, we have data, we try to analyze that, and we try to use that to help practitioners know what's going to work and what's not going to work.
Mr. Chairman, I have a couple more areas. Okay. The two other places I wanted to mention have to do with telehealth and the crisis in Fulton County and the metro region around HIV and the availability of the new medicines. In my conversation with the pediatricians, I asked them what the pediatricians were saying were the biggest problems, and the problems had to do with mental health resources and autism resources. And I know that public health at some point was helping to train some psychologists through the Emory Autism Center to provide more services. Are you continuing to do that?
Yes, indeed. And we worked closely with Medicaid also on that, because it's really important to get funding to support the work that pediatricians in the community are doing in identifying the autistic children. And our early brain development initiatives are also really valuable, because as we are looking for these pathways being developed, there are certain things that are showing up in these children early on that can be identified, and we can prevent an autistic child from becoming a disruptive child. We can basically take steps that will allow that child, through language nutrition, to be on a regular track in school even, which is an amazing change.
Last thing is the HIV issue, which you and I have talked about before, but I know there is a project ongoing in the county, several counties, to actually provide screening. The manufacturers apparently have been willing to provide some free of the new preventive drug, which would be wonderful, but the people need to be screened to know that they need it. And I hope that you will support that effort in whatever way you can.
Absolutely.
So there are a lot
we're
of
very
things
concerned that the numbers in Georgia are extraordinarily bad, and particularly in Greater Atlanta. And also, I'm currently the commissioner. I'm also filling in as the Fulton Health Director. And the PrEP program in Fulton, we were so optimistic that this was really going to be different from other PrEP programs. The main problem with this administering the antiretroviral drug before somebody becomes infected and keeping them from becoming infected is that we've had very poor compliance, and people drop out of the program. But when we were able to get one of the drug companies to agree to give free drugs, we thought, well, that was the real reason people dropped out, because the medication is so expensive. I looked at the numbers last Friday. Our retention rate was no better.
Behavior change is hard. Thank you, Mr. Chairman.
Yes, thank you, Chairman, and thank you, Dr. O'Neill. I had a quick question for you. You had mentioned some of the laboratory needs and a new staff member to deal with TB, and you had mentioned that we have a real major issue with TB in Georgia. Can you explain to us just briefly why that is and where that's coming from? Kind of where are we with that right now, a little more deeply?
Compared to other states, we're not doing really that badly, but any TB is bad. We do have a couple of situations that we need to be watching very closely, though, because of the issues that we're facing with illicit drugs, particularly injectable illicit drugs. We have a group of individuals that do not want any intervention with, quote, a government entity, because they are typically involved with other illegal activities. In North Georgia, along the Tennessee line, we've got a series of situations, two of which have resistant TB. And being able to, we do what we call DOT, directly observed therapy. We send a nurse out there to watch the patient take their medication, to assure that they're getting the medication to eradicate the TB. In this particular area, the nurses have been literally threatened, chased out of the house with weapons because they don't want anybody in there. That's been a real challenge for us. We have made some headway recently, but it's been very problematic. And with the opioid and other drug crisis that we're facing, I hate to say I predict that it's going to get worse, but I fear that it may. Those folks live typically in very confined circumstances. And when they're on certain drugs, they could care less about their sanitary habits. So if you've got anybody in that type of setting with TB, it's going to spread. So that's an issue. We have had certainly some foreign-born tuberculosis, but the amount has not been that great, frankly. The program for the individuals that have come in officially, Refugee Health, those folks are very carefully monitored before they leave their country. After they get here for 8 months, they have ongoing health care through Medicaid. A lot of those folks have had TB and are treated so that they may not show any signs of it, but they actually have a positive test. So we still put those people on treatment because that can break out at any point in time. We've had a fair number in the refugee community like that, but we've really not had any ongoing transmission, with a couple of exceptions in DeKalb County, in the area where a lot of those folks have settled. Thank you.
Thank you. Any other questions? Dr. O'Neill, I've got a couple of comments and a question. You touched on this maternal mortality. I think all of us have had a lot of people that have come to us and expressed their concern and their interest in trying to do something to improve this. And we've got several different approaches by different groups, and I think we need to sort of sort through that so that we make sure we're all singing off the same page and probably get the best result. But I think there's a real interest in trying to do something about that. So I suspect you're going to hear more about that from us too. And the other question I have, you mentioned the PDMP, and that seems to be working well to keep up with the use of the drugs and who's prescribing and who's taking and that sort of thing. My question is this, though, in reviewing the budget, I'm concerned that is there enough dollars in that budget to allow us to continue to move forward with that and maybe even enhance it, like a couple of things that you suggested that we do that will make it more efficient. And the way it's going to be more efficient is when the providers feel more comfortable using it and it's easier to enter that information. I think you'll get better compliance with it. So I guess my question is this. I'm concerned that there may not be the funds in there that we need to make that happen. And would you want to comment on that?
Yes, I think that there is additional funding that's going to be needed to develop this integration. I think the PDMP, in terms of getting people signed up, getting people, the prescribers and the pharmacists doing what they need to do, is occurring. I do think that we will get far better compliance in terms of meaningful use of the PDMP by the practitioners if we make it a lot easier. The time that it takes to go into a separate portal is very frustrating to a busy physician. And if we can proceed with this integration and get it across the state, and it's going to take probably, to keep that going, it's probably going to take an additional $3 million a year to maintain that integrated system.
Good. Thank you. That's what I wanted to hear. Thank you very much for your presentation, and thank you for the work that you're doing all across this state. We appreciate that.
And thank you, Mr. Chairman. We appreciate the work of all the legislators, too.
Thank you. Okay, our last presenter is Dennis Troughton, who is Director of the Georgia Drugs and Narcotics. So Dennis, come on up.
Good afternoon, sirs and ladies, and thank you, Mr. Chairman, for having me here. If I look a little out of place, that's because I don't do this very often. So thank you for having me over. I didn't see you for the amended budget earlier this year because we didn't have anything on that. Greatly appreciate Tara's help. She is, I guess I'm the budget department. They're the Drugs and Narcotics Agency, and she has been very helpful to guide me over here and to speak with y'all. We're a small agency, and by looking at the numbers, I'm sure for y'all, this is really small, and that includes very few people. We have 10 agents, a deputy director, myself, and 2 office staff. So the agency, but what we do, we are the enforcement arm, and I don't, most of you know this, we're the enforcement arm for the Board of Pharmacy, Georgia Board of Pharmacy, and that entails all inspections, all investigations for the Georgia Board of Pharmacy. So that includes in-state facilities, 2,500 pharmacies, and investigations of complaints or issues for over 49,000 licenses that they issue. And our mission statement is to protect the health, safety, and welfare of the public by ensuring all the laws pertaining to pharmacy, dangerous drugs, and controlled substances are followed by both the registrants and any others who handle or possess pharmaceuticals. That's a lot of people in the state of Georgia that we're overseeing, and that's a lot of drugs, as y'all see, I'm sure, from the PDMP information, which we used to administer, and thank goodness it went to the Department of Public Health because they have the people and the ability to administer that program and to grow it and enhance it, and that was huge because that's a terrific program, and our pharmacists use it every day. All day, every day, and they're required. They're the ones putting the information in, so we appreciate the Department of Public Health and what they're doing as far as that goes. One unique thing that affects our budget that I will just want to mention to you is that our agents are all pharmacists like myself. I've been a pharmacist for 32 years, and I've been a cop for 20. And our agents, every one of them, are pharmacists and post-certified police officers. So it's a small number of agents we've got, but I think what we do is critical in the oversight of pharmacy in Georgia. And as we all know, I know you've heard so much information on the opioid crisis, but if you look at it, pharmacies and pharmacists are the gatekeepers for that part of the opioid crisis that is prescription drugs, and that's a big part. You know, they start, where does the most common place that opioid products for people under 18 get out? Out of the medicine cabinet. That's where it starts. You know, and so that feeds back into pharmacy, and also what we do is not just pharmacies. We certainly work with and do investigations with local law enforcement, other state law enforcement agencies, and federal agencies, FDA included, DEA diversion. So we cover a lot of ground in our agency, and our budget, as you can see, I think was 2 lines there, and we appreciate the governor's enhancement to that. I would ask for a couple additional items, and y'all forgive me. I would say mine's in paper. It's not on the screen. I apologize, and it was paper format that I gave to you. The 2 major or 2 enhancements that I would ask consideration for, if in fact there's any ability to any money left over, maybe I should say it that way. We use our agency's been around since 1908, but we are using Excel and Word. That's our technology system to keep up with investigations, the licensure, because our investigations include pre-licensing investigations when there's an issue. They call us to follow up and investigate it. So we use, and I think we do a darn good job with Excel and Word. Now, my folks will tell you I'm a little technically challenged, and I am, but that's really one of the major enhancements that we would like to get a system, being law enforcement, because we have to wear the administrative hat as well as the criminal hat. And so we treat every investigation as it's criminal, but they split up at some point. We need a system that is catered to us, formatted and fitted for us to be able to provide the information we need to get it to my agents on the street, but also to provide it to you folks, to Department of Public Health. We would follow up on their PD&P investigations. That we would be the ones they would call to do that. We assist the medical board, dental board, any healthcare board. So that one-time startup for a system that we've looked at several, $125,000 for the initial year, $20,000 as a recurring maintenance fee. I would request a person that had the knowledge beyond what I've got and some of us to maintain that system for us in office, meaning a administrative assistant type spot to make sure we utilize in that program as well as we could and could stay current and with it. The other enhancement I would ask for, and I'm sure every agency has asked you for, I've got 9 full-time agents, 1 part-time. That's covering 159 counties and, like I said, 2,500 pharmacies and every investigation that goes. And I don't mean that we need it. We're more important than anybody else, but that hat we wear as pharmacists, we are called on very often to come in and assist that investigation because most law enforcement, pharmacy is a different world. It's a world of its own. And so my investigators, like I said, we have to maintain our license in the pharmacy, and that's all we do. Like old Clint Eastwood said, man's got to know his limitations. We know ours, and it's pharmacy, and it's medicine and healthcare, so we become quasi-experts in investigations and in that realm of the world. The opioid crisis is putting more demands on everybody. We're one of the agencies deeply involved in the initiative the Attorney General's put forward in that arena. So the cost of an agent initially, because we provide them a vehicle, but benefits, salary, everything, $137,000 a year. I'd request 20 agents if you'd give them, but we would be grateful for any enhancement we got, and be glad to answer any questions I can for you.
Okay. Representative Petrie has a question for you.
Yes, sir. Thank you, Mr. Chairman, and thank you for being here today, sir. Tell me, so you're asking for 2 additional full-time agents. How do you do with recruiting? Because this is a very unique job for a pharmacist, and as you know better than anybody as a pharmacist. So how do you do when you go to recruit and you have 1 or 2 new slots to fill? How do you do with recruiting?
Well, until 2 years ago, and I got to thank the chairman here, and we got an improvement last year in the base salary, because what I'm doing is recruiting pharmacists who are making an average of $120,000 a year. So I had 4 positions open for 5 years. You just couldn't recruit them because you'd go out there, unless they'd lost their job for some reason and didn't have one. When you say, well, you're making 120, but we can only pay you 75. We are up to the base salary of 84 now, which was from last year, and the help we got for that. And 2 years ago, we got a portion of the law enforcement bump that Governor Deal suggested. We got a piece of that. So I feel like our salary, which for an agent is 84, again, you're asking somebody to take a, sizable cut, $35,000 a year cut from an average salary. But you have people like me that I was an agent for years, left for 2 to help make money to get my kids in college, and then came back, so I'm obviously the sharpest tool in the shed. But it's those people that we look for who want something different, and who we're the kind of the thin line for pharmacy as far as regulation of pharmacies and being in those shops. And so I'm very passionate about what we do, and that's how we do it, is to recruit them on that.
Thank you. And so right now, you, because of these adjustments that sounds like were very necessary and needed, you actually feel pretty confident about your ability to recruit where you are. Is that what I'm hearing you say?
I do, yes, sir.
Okay, thank you.
In
Thank
fact,
you, sir.
in the last year, we've been able to get 2 to fill of those 4 spots.
Thank you, sir.
Yes, sir.
Okay, any other questions from anybody? Okay, Representative Hawkins has a question.
My concern over the program, PDMP program, has always been, we're asking physicians, dentists and all, to check the records on each patient. I know other states had a real-time system set up, so when we'd write the scripts, the pharmacist would type our name in, type the patient's name up, and that would pop up a couple things. One, if the patient got them in other locations. Also, if it did not parallel our normal writing patterns, like I have never really written for more than 3 days anyway. If they need more than that, something else is wrong. But so my question is really related to this. Do you have a feeling on how often the physician is finding that there is a problem with the patient? I mean, he's checking on every patient if he writes more than 3 days. Is this a productive approach to this?
And so when we helped start that PDMP,
Yeah.
Our side of it was sort of the administrative. I could tell you a lot better about the pharmacist. Oh,
Okay. That's fine.
Being one, and that's our central.
Right.
I know the most difficult part of beginning that whole program was just that, getting pharmacists and physicians to look.
Right.
So now physicians, have to look.
Right.
We'll begin to. The pharmacist still, that's not a part of the program, but I know it's increased because I'm on that advisory committee with that Dr. O'Neill was talking about, and it's going the right direction. The use of it, I think it's going the right direction. I think it's like somebody mentioned earlier, habits are hard to change, and a lot of it just appears to me with pharmacists too, because they don't have to look, especially. It's that habit and convincing them of how good this tool is to help prevent the problem we got. It's convincing them to use that tool that they hadn't used for, especially old dogs like me. I'm not filling those prescriptions, and I'm not used to stopping for 2 or 3 minutes. And that's part of the issue with pharmacists too, I believe. Just what he addressed, and they're trying to improve. I got to stop my workflow.
Right.
And look, not realizing how important that minute and a half is. And with the delegates, when they changed the law last year to allow delegates, I think that's a great step to not having to be that physician anymore, not having to be the pharmacist. Big deal. I mean, I think, so some changes have happened with that. Again, we're not overseeing it anymore, but we see it as the inspectors.
All right. You just mentioned something I'm not aware of then. So we have to check if we're writing more than 3 days script. So the pharmacist is double checking also when the patient brings the script in?
Well, they certainly can. Oh, yes, sir. They can.
Are they required to by law?
I don't believe they're required by law to.
I don't think they are either.
To
so really
check.
The check is happening at the prescriber level.
Well, I can say this as an inspector and with my agents, as we do inspections,
Right.
Because part of what we help Department of Public Health with, if a pharmacy is not reporting, because now it is a daily reporting system, right?
When you fill, you're not checking on the patient. You're just reporting the number that you fill, right?
Oh, no. Well, you're not required. You're right. That pharmacist is not necessarily required. He's not required by law to look at Dennis Trofton and what Dennis took. Right. So his computer is required to report every day.
Right.
But there is not a law. That's not part of that law that says, as I'm filling that script, I've got to look Dennis Trofton's name up in the PDMP.
See if he's getting it somewhere else.
Yes,
right?
sir.
Dr. Shop. Okay.
Okay. Dennis, if you were to be able to upgrade your IT system, would that in effect make your other operations more effective or easier to administer, or what?
Yes, sir. I think it would absolutely make the internal workings of our agency better. Again, if you can imagine this, because everything's on paper, not just from agent to agency. That's one big plus, because an agent's out there needs the support and the information from the office. They can't tap into it, and they have to literally call, can you get that file? Can you pull this, pull that file for me? So, that 30 seconds per phone call that we save may not seem like much today, but man, in the big picture, that's another half employee that I've saved over the period of the year that I can have helping to, again, support my agents in the field, but then also like the litigation opioid, that the records and things that we're being requested, and we're going back and pulling files and reading reports. What reports started with opioid? Which ones were tied to opioids? Because that's not how we filed them for the last 20 years. So I think it'd be a tremendous benefit to everybody for much better ability to give you statistics, and because I know numbers are important, certainly. So I do. I think actually anything before 2003 is on an index card that we check the file of. So it seems funny, but it's not when you're going.
Right. Okay, great. Any other questions? Thank you, Dennis. Appreciate you being here in your presentation. That concludes our presentation today. And let me just remind everyone that in the morning at 8 o'clock in room 506 over at the Legislative Office Building, we will have a public hearing on the FY20 budget, 8 a.m., 506 CLOB. So we'd invite you to come if you have an interest in being there or making a comment. I want to thank the members for coming this afternoon. I know there's a lot of things going on, but this is important. We appreciate it, and we're adjourned.